Welcome to this workshop. We are from UVD Robots in Denmark, and we are going to talk about what we're doing in Denmark, the Danish Healthcare Authority. How are they fighting against the hospital-acquired infections by using robotic devices? That's the story we're going to tell today. And just a short presentation of myself. I'm Per, and I'm the CEO of UVD Robots. I've been in engineering and business administration, 20 years in different types of management roles in many different companies. But what is important is the last 10 years I've been CEO in companies heading up different hygiene solutions, and over the last year and a half, CEO of UVD Robots. As co-speaker today, we have Simon Ellison. Hello. Simon is from the UK. He's born in Manchester, but he's now living in Denmark, working for us. And he has a long career in the British Army, and also a long career in medical devices and decontamination and infection prevention and control equipment. So, and apart from us, we have Professor Val Jones, with us from Spain. Welcome, Val.
Hello.
And we'll come back to Val, because she actually did some of the testing, which we'll come back to. So let's get started. We're from Denmark. Denmark is not that far from the UK, where we are now. What is Denmark? Denmark is probably well known for Lego. The Lego toys founded in 1932. But unfortunately, also here in the UK, we are known as the Vikings, who invaded the UK in 793. Sorry about that. But back to Denmark. What are we doing in Denmark? What is the healthcare structure in Denmark? We have 5 different regions, healthcare regions, running their own healthcare systems in Denmark. We are approximately 5.6 million people, so it's not a lot compared to the UK. I think that's something like Greater Manchester in terms of number of people, so not a lot. But we do work seriously with our problems, and we do actually have problems in the Danish healthcare system. We go back some years into around 2007, where we see the start of a new future, because at that time the Danish government, they were discussing ambitious plans to launch new super hospitals, actually 6 new super hospitals they wanted to launch, because they wanted to really restructure the Danish healthcare sector. And that was a major thing at that time. It was discussed over a number of years, and finally it was made, a political decision was made, and it decided to build 6 new super hospitals in the 5 regions. We are coming from the middle region. It's a small island, Funen, in the middle. But each region got their own super hospital plan for at that time. Funds were allocated by the Danish government, 40 billion Danish kroner. That is something like 5 billion pounds was allocated for building those new super hospitals, they were called, because they really wanted to change the structure, take in the latest technology, and do the best possible hospital service at that time. Takes time, those projects. Actually, you see here, Nyt OUH, which means a new Odense University Hospital, started on a field just outside Odense, near the university center. The old hospital in Odense were in the city center. Now we are moving to a complete new site. And actually in 2016, the 2 politicians, together with some local kids, started the building by digging the first digs for the foundation of the super hospital in Odense as one of the 6 ones. So that's really great. We got 40 billion Danish kroner. That's also really great. It's a lot of money. We really want to do the best for our patients and for the citizens in Denmark. But there's a big problem. And what is a big problem? The big problem is that we are going from hospitals to super hospitals. But there's a worrying simile, because at the same time we also saw the box going from normal box to super box. So an even bigger problem. And we have a famous professor in Denmark, and John Kolmos, professor in microbiology. He said it is a big problem. At that time, MRSA was really a big thing in the press and in the hospitals. And he said, we got to take it seriously. We're not doing enough. We got to do more. It's a very, very critical situation. It even gets worse. Professor Kolmos and another colleague, a professor in finance and economy, they made a report where they were analyzing the hospital infections, financial consequences, and that is really an eye-opener at that time. The conclusion was that between 20 and 50% of the hospital-acquired infections can actually be prevented if we just do the right things. So, what was the situation in Denmark? The situation was, and still is, we actually have 50,000 hospital-acquired infection cases per year, 7 to 10% of all patients being hospitalized. They acquire an infection. We've got 3,000 people dying every year. Maybe 3,000 is not that many compared to UK, but a small country like ours, 5.5 million 5.5 million citizens, that's quite a number of people dying from infections. And we have the costs, let's say unnecessary costs in the healthcare sector, 1 billion Danish kroner every year due to those problems. So there was a dilemma, a political dilemma at that time. We were very proud of the new super hospitals, sparkling new hospitals, but unfortunately the same old problems if we didn't do things differently. So, the healthcare authority, they looked at ways to overcome that. They were talking together, the 5 regions, each of them running their own hospital systems, and they said, we got to do something. And they decided to, so to speak, grab the bull by the horns. Let's do something, let's find a solution where we in the future can reduce the number of infections, reduce the number of people dying from infections at hospitals. So that's what they wanted to do. They wanted some great ideas. They also wanted some money to fund the great ideas. And luckily it turned out that a government fund called the Market Maturation Fund or Markedsmodningsfonden in Danish. It's a fund funding new technologies, new innovations. They formed a partnership, in Danish, sygehuspartnerskabet, or in English, a hospital partnership. So they decided, the regions running the healthcare systems, the hospitals, and the foundations said, we gotta find a solution. They made a project outline. The main theme was to reduce the number of infections in Danish hospitals. It's described here. It's a little bit complicated, so to make a long story short, what's that? In English, please. Find new innovative ways to deal with hospital infections. Basically, that was a task they were tasked with. And that was set up. And to make a long story short, the result of that was actually that the outcome, what was the solution? The solution was UVC technology. And that's where our story starts about UVC technology. I think, Simon, you will take over from here and go into more specific
I'll just go
details.
one slide back from Per. They asked the industry, they asked a lot of different companies.
Sorry, Simon, I'll need you on the microphone later.
Sorry. I do like to walk around, so. They actually approached the industry and requested as many ideas. It doesn't matter how outrageous or how unrealistic it seems. We need ideas and we need to find a solution. So, I mean, this process went on for years. And eventually it came down to the last one, and it was agreed that UVC had the most potential to help. Now, UVC, I'm sure everyone in the room knows about UVC and its application, but UVC has a very useful characteristic. It's this germicidal radiation effect. Typical UVC bulb, that's one here, emits light at 254 nanometers, and this is the same type of bulb you will find in the majority of UVC equipment. UVC is actually created by the sun, together with UVA and UVB. UVA is what makes you nice and brown. UVB is when you get a little bit too red. UVC doesn't hit the surface. It is completely filtered by the atmosphere. And that is the reason why it's so effective in killing bacteria, organisms, because they have developed no natural resistance against it. And I know what you're saying. All this money, etc., UVC, it's not a new innovation. We already know about it. And you're correct. We do know a lot about it. In fact, we know extreme amounts of facts about it. We know, for example, exactly how much dosage of UV is required for all organisms. Here's a very, very good one. And when I say we know exactly how much UV is required to reach the different log reductions. So it is very well known and very well used. However, there was a problem for the Danish Health Authority. There was something missing from UV. And despite all this overwhelming data, clinical reports about how effective UV is, we have a group of non-believers. And they are our physicists and their laws of light. And what our physicists tell us is that light, if you put an object in the way of light, it will cast a shadow. Yeah? We all know this, it's basic physics, primary school physics. The second, which maybe isn't as well known, is the inverse square law. I know the two young gentlemen at the front know about it because they just spoke to me. But the inverse square law is a law that tells us how the light intensity acts. And it's quite simple. Basically, if you're 1 meter away from a light source, the amount of light that will hit that source, the amount of light from that source that will hit that object has a certain intensity. Now, if I double that intensity to 2 meters, so I've doubled the distance, you would logically think, double the distance, half the intensity. It isn't actually true. Double the distance, a quarter of the intensity. Treble the distance, in other words, from 1 meter to 3 meters, the intensity falls to a ninth. A 16th by 4 meters, 1/25th by 5 meters, and so on. So these are the two laws of light that govern all types of light, including UV, and they were the 2 points that we had an issue with in Denmark. You know, UV is fantastic, it works, but in the reality of a patient room, an operating theatre, you have to address these two options. So, back to the drawing board. What can we do to make UV much more effective? What can we do to get around problems like shadowing, distance? Yeah. Some interesting solutions. Number one, we could put something into the patient room which we know bends light, for example, a black hole. It's a suggestion. It's a little bit unrealistic, but it does bend light. Or we could get somebody to move the UV light around for us. It's also an option. Denmark, however, the basic salaries start approximately the 30,000 plus range. So having somebody doing that on a full-time basis is, it's an expensive exercise. And then some bright spark came up with the problem, oh, you can't use people and UV at the same time anyway. You know, it's harmful to humans. So we have to get rid of that. But there must be something that we can do. What do we normally do? What do humans normally do when we have to go somewhere that is too dangerous for us? We send a robot. Now, obviously, I come from the British Army, as Per said, and even back in the 80s, we were using robots, sending robots into dangerous places to defuse bombs. We use robots at nuclear power stations because we cannot go there. And we send robots to Mars because we cannot get there. So the idea of using a robot when we talk about UVC, that was a good idea. So the hospital partnership then sat down and said, right, who knows about robots? No, nobody knew about robots. But as luck would have it, at the same time the Danish healthcare system was going through this change, there was also another industry that was going through a boom. And that happened to be the Danish robotics industry. I don't know if anybody speaks German here, but there's an interesting article in the equivalent of the German Financial Times where they call Odense, Per's hometown, the new super hospital, and where we are based, the new mecca when it comes to the robotic world. So, interesting. In particular, there was a company called Blue Ocean Robotics based in Odense, and a group of young, very innovative robotic technicians, I would say, or maybe just innovators. And it was decided by the hospital partnership that we're going to team up with Blue Ocean Robotics. Because Blue Ocean Robotics had a very interesting concept called RobiX. And RobiX is a concept that allows companies, any institute basically, any group of people to build and have a very proactive part in designing their own robot for their particular needs. And the hospital partnership thought this was a fantastic idea because it gave them the chance to say, right, well, we need a robot to do a specific task, and we can get involved with building that robot. So in 2015, it was decided that we would, the hospital partnership, together with Blue Ocean, embark on this project. And there were some critical criteria, requirements that the healthcare system asked for. And one of those was, of course, reduction of shadow area. We need to see that. Closer proximity to surfaces. We want to be able to get the UV very close where we know it's effective. Quicker turnaround of patient rooms and operating theatres. Lower workload for staff. And very important, the ability to create room validation reports. Per and I come from the instrument washer business, where after every wash, every cycle, you get a report. And that report is filed for traceability. However, this is something that we are not currently able to do in the room disinfection and the room cleaning process, because it's mainly a manual system and there is no precise repetition. So dealing with robots, this becomes an option, and this is something that they thought would be an excellent idea to be able to now validate the disinfection process. And it was also decided that Professor Colmus, who had been very, I would say, very verbal and very well known in the negative side of hospital infections and the problems that brings. As he was based in Odense, it was decided that he would actually, and his team, microbiology team, would be a part of this process. They would test the robot, they would do the lab testing, they would do user friendliness, etc. So they would play a very, very active role in this situation. And additionally, we would have to go, of course, to the Danish Technological Institute for third-party lab testing. So off we started, ideas were formed, etc. And in 2017, the UVD robot was born. And here, he or she comes. I've made it drive extremely slow in this area for the simple reason I didn't know if people would have their legs out or their bags or whatever, so So Blue Ocean Robotics handed over the UVD robot to Odense University Hospital, Professor Kolmos and his team. And they commenced their testing. And what they did first of all was they deliberately contaminated 84 positions in a patient room. They then, it doesn't normally drive this fast, we made it just for demonstration. They then let the robot disinfect for 15 minutes. Here's a part of the film. To give you an idea. They then found out that the robot had actually got to 100% of those positions, and it was able to radiate UVC at a maximum of 1 meter distance in every single case. So their field tests, they got the results they wanted. Then we move on to the lab tests, and at the time, you know, MRSA was the issue, E. coli was the issue. So those were the organisms that were tested, and we got fantastic results with those. Then we moved on to the room coverage. They wanted some kind of visual confirmation that the UVC was actually getting to all the areas of the room. And what they very cleverly did was they substituted the UVC lamps with visible light lamp. And then they were able to measure with equipment this light intensity map. And you can see where I'm going with this. A UV system that is able to maneuver around, the most intense light moves with it. And if we were to superimpose these pictures on top of each other, there is a very, very, I'll say, clear picture of the amount of light, UV light, in that room. The fourth part of the test was the user friendliness test. They gave it to the infection control staff. You know, they showed them how to use it, and off they went disinfecting patient rooms. On top of that, we did the mandatory lab testing, you know, and yeah, the results speak for themselves. The bacteria, we were getting, well, 5.7 to 7 log reduction. Fungi, even 5. Bacterial spores. I'm going to go very quickly through this because we've done this in the UK since. So, and the director of the hospital had some very nice things to say about it. He actually said something interesting that it's also going to help his staff stay at work because the amount of sick days that he was going through was a problem. So, very interesting. And just to get to the end of that, we have a nice picture of some politicians, the microbiology team, and even Professor Kolmos seems to look quite happy about it. So everybody was happy. An interesting thing happened then. We seemed to get continuous media coverage about these super robots that were going to save us from all these nasty bacteria. It literally was continuous. Every time a new hospital planned to get a robot, it was in a newspaper. So it created a massive, I would like to say, a positive media coverage around these robots and you know, the solution to our problem. So, but at the end of the day, after nearly 5 years, did we get the job done? Do we reduce shadow area? Well, the fact that the robot can move around the shadow, I think that's a definite yes. Do we get closer to surfaces? It's mobile, so yes. Quicker turnaround of rooms? Well, yeah, we're talking 10, 20, even if 30 minutes. You want to do an intense disinfection, it's still a very, very quick alternative to disinfection. Lower workload for staff, without a doubt. You know, the only interaction a member of staff needs to have with this robot is telling it which room to disinfect, to open the door to let it in, and then just to check if there's no patients in the room, and that's it. And the robot does the rest for you. Creation of room disinfection, validation reports, of course. The robot will tell you after every disinfection what day I did it, what time I did it, if there was any problems, is it a pass or a fail, was I able to get to every spot, was there any obstacles, etc., etc. And the fact that it's a robot, it goes to the exact same position every single time. Yeah, and I'm moving on. Cost effectiveness was one of the issues that we had to deal with. Now, normally, when you introduce a robotic version to a manual product, you expect it to be a lot more expensive. What we actually found out was that we were, price-wise, especially in the Danish market, price-wise about the same or even lower than some of our colleagues. So that was an interesting, and it actually works out for the Danish hospitals, the cost of a quint of £1.97 to disinfect a room. And that price is including the purchase price, the installation cost, validation, replacement lamps, and the projected spare parts requirement. So it was, I think, a very cost-effective solution. And at £1.97, you've got to ask yourself the question, do you really need, or the question, not if I can afford it, the question is, can I afford not to have it? So it's very interesting. Right, so what has this got to do with England? Danish company, Danish healthcare system. I mean, there is a long history of Denmark and England working together. All the bacon that Denmark makes comes to England. And as an Englishman in Denmark, it is one of my pet hates. You know, I cannot even get Danish bacon in Denmark, but it's, you know, we work very closely together. And in October 2018, the guys from Knowlex contacted us and says, we've seen this robot of yours. We need to know more. And to be honest, I thought they were just trying to sell me space at a conference. But they said, no, they are responsible for bringing innovation to the NHS. They're looking for new ideas constantly. They've seen the robot, they need to know more. And Adam, who we've all seen today, came over to visit us in Denmark, and that was followed up by a visit to Arab Health in January. About the same time, I was invited to Salford Royal and said, we've heard about this robot, we need to have a look at it. So I went over there, did a demonstration, very, very excited, very impressed. One criticism, the organisms that you've tested were a problem some years ago, but now we are facing new problems. CPE, Acinetobacter baumannii, and C. diff spores. We want you to test those in a UK lab. So we said, okay, fine. We contacted Knowlex again and said, who should we be approaching to do this testing for us? And they said, go to Melbeck Microbiology. And that's what we did. And Val wanted to be here to present this herself. She was unable to. So we arranged for Val to be filmed and for her to present herself the results.
Hi, I'd like to introduce myself. I'm Professor Valerie Edwards-Jones. I'm an Emeritus Professor of Medical Microbiology from Manchester Metropolitan University. I'm also an independent microbiology consultant, and I was asked through Knowlex if I could help to evaluate a robotic UV system And I did this with the laboratory Melbeck Microbiology in the Northwest. So this is a presentation about the evaluation and the organisms that we used and the results we obtained. So one of the biggest problems we face in the UK going forward and globally is the threat of antimicrobial resistance. It has become bigger and more of a threat over the last 20 years as we've started to realise many of the common pathogens we see on a day-to-day basis are resistant to the common antibiotics that we use to treat infection with. If this persists and continues, it will be the end of modern medicine as we know it. You won't dare go into hospital and have something like cancer treatment or a bone marrow transplant when you're at risk of acquiring a healthcare associated infection which can't be treated with antibiotics. So it is a huge global risk, a huge global threat that's going forward, bigger than cancer, bigger than diabetes. So we are faced with the challenges of trying to eradicate superbugs. Sometimes the term superbugs can actually be misleading. And most people think when you talk about superbugs that they are very, very difficult to get rid of. Well, they are if the patient has sepsis or they have an infection associated with one of these superbugs. However, they are just bacteria as we've known and loved them. What they have is they have genes within their DNA that encode for resistance to the common antibiotics. So they are antimicrobial resistant. They are still susceptible to many disinfectants. They are still susceptible to many alternative treatments. And as such, they are susceptible to ultraviolet light. How does ultraviolet light work? Well, it works by interfering with DNA. So it passes through the cells very quickly with photons and it intercalates with the DNA within the cell. And you have to remember bacteria do not have a nuclear membrane, so it interferes directly with DNA and it causes what you call dimers. So the DNA is made up of lots and lots of amino acids on a particular chain. It's all twisted, etc., if you remember DNA biology. But what it forms the amino acids to actually link together, so it disrupts the DNA. And unfortunately, after the UV has had a go at this DNA, it's very, very difficult to repair. It also intercalates and disrupts DNA very, very, very quickly, within minutes. Not within hours, but within minutes. So it makes UV a very good alternative for disinfection of the environment or a room. We've actually used ultraviolet light in laboratories for many, many years. We use it in cabinets to disinfect the air. We always have a particular glass shield in front when we're using it. We have our arms in cabinets, but we use it when we're undertaking aseptic techniques. So microbiologists have known for a long time that UV is excellent. However, it's more difficult to get integrated into the hospital environment as a routine decontamination device because there are problems with things like shadowing, etc., in the environment. And if you just think about it, if you have anything that is placed in front of the UV device, it will form a shadow. So the amount of UV that will be hitting something within the shadow, and if it's a bacterium, it means it's not receiving the amount of UV it needs to disrupt the DNA. So people have been very concerned about shadowing and shadowing effects with many of the UV devices. And it is a problem, and I've done many studies now, and I've shown that when you are in very deep shadow, the reduction in organism numbers, that's usually very rapid, is decreased quite markedly. So we were approached by UV disinfection robots company to actually undertake a study in the UK. They had done previous studies in Denmark, and showed us the data from that, which looked extremely encouraging. So previous studies were undertaken in Denmark using the 4 common organisms that are used for disinfection testing. These are Staph aureus, Enterococcus hierae, Pseudomonas aeruginosa and E. coli. Now there are subtle differences between the Staphs and the Enterococcus and the Pseudomonas and the E. coli. So the Staph and Enterococcus are gram-positive organisms, frequently found in dust. Pseudomonas aeruginosa and E. coli are usually found in wetter areas, so such as bathrooms, etc. Staph aureus and Enterococcus are far more hardy in the environment. They survive longer in the environment, whereas Pseudomonas and E. coli don't survive very long in a dry environment. So these organisms were tested and they were exposed to the UVD robot in a hospital setting. And what was found was that there was a greater than 5 log reduction in organism numbers within a 5-minute period, a 5-minute exposure time, when these organisms were actually placed on coupons and in proximity of the robot. Usually they're tested at a 1 metre proximity. And greater than 5 log in 5 minutes is absolutely exceptional if you think about it. So we're taking it down from 100,000 cells to 0 in 5 minutes. 10 to the 5 organisms, colony forming units. That is massive. A 5 log reduction is amazing in 5 minutes. So, UV light emission in any room, you know, the future of it could be quite astounding, because you could do the terminal clean of the room as the patient leaves the room, and then you could put your UV light in, operated for however many minutes are determined within your hospital, and you know that you're going to get a huge log reduction of organisms on the surfaces and in the air in that particular patient room. So quite dramatic. In real life situations, if we think about the shadowing problem, how do we get away from UV not working in a shadowed area? Are we going to have to open everything up? Are we going to have to turn things around? What's interesting about UVD robots are the fact that they can move. So they have the opportunity, and you can program the robot to move to near the area where the shadowing is occurring, and you still then have UV light actually being displayed in that area. And the tests that have been done in the laboratory, and certainly in our study, were done within a 1 metre proximity, and that's very important. A greater distance that the UV light has to travel, the less kill you get. So the study was actually created at Melbeck to actually determine how the robot may operate in a room. So we placed a robot in an empty facility. We placed 2 very large boards up in this facility, so it created shadows. We placed the stainless steel coupons with the organisms in the shadowed areas of this facility, and we allowed the UVD robot to move between the centre and where the shadowed areas were in 2 positions. So stainless steel discs, which we call coupons, were placed in these shadowed areas. We actually placed on the surface of these coupons, we placed a minimum of 10 to the 7 organisms. Now, when we talk about 10 to the 7, people can't visualise that. So it is 10 million cells are placed in 50 microlitre drop. We then allow them to dry on the surface for 30 minutes. We place them in the shadowed area, and we then set up the experiments. And we decided to test some of the multi-drug resistant organisms that are very prevalent in hospitals today. So we looked at Clostridium difficile spores, we looked at CPE, carbapenemase resistant Enterobacteriaceae, and we chose a Klebsiella pneumoniae, which is known to be carbapenemase resistant. And we also used Acinetobacter baumannii, which again is an environmental organism causing lots of problems in hospitals. So we seeded the coupons with these organisms. We exposed them to UV light for a set amount of time, and we looked at 3 minutes, 5 minutes and 10 minutes, 15 minutes for spores only because spores are more difficult to kill. And we also had control coupons placed in the same positions. These control coupons were seeded at the same time. The control coupons were placed in a Petri dish with wrapped up, triple wrapped with tin foil so the UV couldn't penetrate it. And the control coupons actually then were their own controls. We then took the coupons to the laboratory. We placed the coupons in 10 ml of diluent, vortex mixed them to knock any organisms off the coupons, and we serially diluted them so we can ascertain the viable count of the organisms. And that is the number of organisms that are still alive that are remaining on that disc. So bearing in mind, we placed around about 10 to the 7, which is 10 million organisms on the disc when we started. So we had to do enough dilution so we could estimate the accurate numbers. We used UV indicators as well at the same time, and these UV indicators obviously change colour when they're exposed to certain levels of UV light. And you can see for the various organisms that have been tested before, MRSA requires 192 joules for a log 6 reduction, E. coli requires 180 joules for a log 6 reduction, and vegetative, not spores of C. difficile, requires 240 joules for a log 4 reduction. What the UV indicators demonstrated in the laboratory sessions that there was over 1,000 joules given to that area in any 1 minute. So we knew there was plenty of UV light coming from the robot, even in these shadowed areas that we'd set up. And they were, the UV light was killing or should kill the organisms. The study results were very exciting. Klebsiella pneumoniae, which is carbapenemase resistant. This showed a 6 log reduction of organism numbers in 3 minutes. Now, a 6 log reduction, for many people who don't understand that means it's gone down from 1 million cells that were placed on the disc to no cells, or 1 cell. So it's actually killed 1 million cells in 3 minutes. Acinetobacter baumannii, we saw a 7 log reduction in 3 minutes for this organism on the coupons. So that was a 6 log reduction in 3 minutes in both positions for the CPE, and a 7 log reduction in 3 minutes in both positions for the Acinetobacter baumannii. So what about the Clostridium difficile spores? Clostridium difficile spores are really well known for difficult to get rid of. We find them in Hoover bags, we find them in the environment in hospitals, and they can persist in dry environments for a long time. The coat of a spore is very, very difficult to penetrate. So we were expecting these to take longer to kill. However, what we saw was a 4 log reduction in 3 minutes and a 4.5 log reduction at 5 minutes in both positions. And this increased the longer we left it. But a 4 log reduction, that is taking it down from 10,000 spores down to no spores in 4 minutes. That's absolutely amazing results. So in conclusion, we were very impressed with the fact that we had a robot that could be programmed to move around the area to eliminate shadowing. The two positions that we placed the organisms in were in shadowed areas, but the robot was able to move around and be within 1 metre that was required to cause log reduction. Very impressive 4.5 log reduction in Clostridium difficile spores within 5 minutes. A 6 and a 7 log reduction in the 2 gram-negative organisms, CPE and Acinetobacter baumannii, within 3 minutes. So I certainly think, without any hesitation, UV decontamination of the environment is something that we have to think of as a part of our end game and part of our infection control procedures going forward. Thank you very much.
Now, there's a question and answer session on there, but unfortunately time is not on our side. And Val was also here today to answer any questions on the microbiology that people may have, but once again, time. So what I would say is, if you do have any questions about that part, I'm very happy to send you the full video. We've cut a lot of it off to save time, and I know that Val is very keen to answer any questions as the test. So moving quickly on, I mean, we don't need to repeat everything again. The ability of the robot and the effect it could have in disinfection. One thing I would like to say, back to the price. I mean, what do you get for £1.97 today? I actually tried to buy a Coke in my hotel, and I couldn't get it for £2. It cost me £3.50. So, you know, we're not talking here about huge amounts of money, and we're not saying that you should be using UV to replace other existing measures that you take. What we are saying is, for the sake of £1.97, is it not worth it just to add on to your cleaning, disinfection processes? Because if we could save one patient's life a year, I think it's worth the £1.97.
These particular bacteria were chosen for testing at Melbeck because they are problematic in the UK. The CPE is on the rise, Acinetobacter baumannii is on the rise, and C. difficile spores are very difficult to kill. Yeah, hospital-acquired infections are a real problem. If we've got people going in for cancer surgery or bone marrow transplants and they acquire an infection from the hospital environment, it's very, very difficult to treat with antibiotics. The worst case scenario is death. Therefore, it's essential that we keep the environment as clean as possible. We do terminal cleaning with disinfectants, but if you could then go in with a UVD robot and you know that you've cleaned the environment, you've caused a 6 to 7 log reduction in however many minutes you use the robot for, it means that you are decreasing the chances of environmental infection. We call these organisms superbugs. However, they're just like any other organism of the same group. They are resistant to certain antibiotics, and these antibiotics are the one that we've been using to get rid of them from the patient for many years. However, these antibiotics now resistant, so we call in these organisms superbugs. However, they're no different to, say, methicillin-sensitive staph or normal E. coli in terms of their sensitivity to UV. So, you know, if you're trying to kill an MRSA, it should just be as easy as killing an ordinary methicillin-sensitive Staph aureus with UV. Certainly E. coli infections acquired from the environment. If you've got an E. coli sepsis, it's obviously not going to help the patient at all. But if you're trying to prevent the patient from acquiring an infection with E. coli, where perhaps it's residing in the environment, it might be residing in the wet environments, in bathrooms. If you can UV decontaminate a bathroom, you're going to reduce numbers of E. coli and you're going to reduce the risk of infection. Most UV devices are static, so you place them in an area in a room that will usually be within one metre of anywhere which could have contamination on the surface. However, you invariably get shadowing. You get shadowing of where perhaps a bed rail is, or a piece of equipment in the room. Behind that piece of equipment, you're going to get shadowing, so the UV isn't going to hit that area, so the bugs will persist. However, if you've got a robot that moves around the room, it can go to areas behind the obstacles and help, make sure that the UV gets exposed to all areas and the shadowing is minimized.